patient I'm presenting to you today is Richard Jones. He's a 70-year-old male. So 4 weeks ago, he was admitted to the ED because of a non-healing ulcer on multiple toes of his left lower extremity. This ulcer also had associated osteomyelitis and impaired perfusions of that area and resulted in a below-the-knee amputation. So he carried out his rehab after amputation in a skilled nursing facility, but he was readmitted into acute care due to sudden onset of confusion and decreased alertness. He was later diagnosed with hyperglycemia with the presence of an infection on his residual limb. This required drainage, and then when they cultured the drainage, they found that the wound was positive for MRSA. So now he's receiving antibiotics through an IV, and he is in our inpatient facility to continue those antibiotics and to begin more intense rehabilitation. His comorbidities is he currently has hypertension, type 2 diabetes, which is uncontrolled, and I'll touch on that later, hyperlipidemia, acid reflux, sleep apnea, COPD, and his past surgical history is he had his gallbladder removed at age 25, he had a total knee on the right side at age 55, and he had 2 cardiac stents placed 5 years ago. So with his uncontrolled type 2 diabetes, there's some risk factors associated with that. He has an increased chance of infection, which we saw with that residual limb. And with that infection, he has delayed wound healing times and poor perfusions to that area. In addition, he also will have atherosclerotic changes to the coronary blood vessels of his heart, which may have been the reason for the need for the stents, and also changes to his cardiac muscle of his heart. And I'll touch on that, why that's important a little bit later. So some yellow flags to keep in mind when working with this patient. He is a fall risk as reported by acute care PT. He also is on contact precautions, so we want to make sure we have our gown, mask, and gloves on when we're with him. He had cardiac stents placed, and he has COPD. So we want to be monitoring his vitals before, during, and after treatments. When I checked his vitals, his last vitals taken, they were normal, but they were at the edges of the extremes of what's acceptable. So we always need to be monitoring those and make sure they don't change too rapidly. Also, he is on 3 liters of oxygen, so we want to make sure that his portable O2 is with us when we mobilize him. He also has been reported to be experiencing orthostatic hypotension. So when we set him up on the bed, just really make sure that he has his pulse ox on and we're monitoring his symptoms and making sure we keep him safe before we move too quickly. And finally, he refused to get out of bed previously. And he said it was due to complaints of dizziness and fatigue, which is most likely due to his medication, his diabetes, and maybe explained by his lab values. So really being patient with him and, expecting possible refusal and being able to deal with that when it happens. In terms of red flags, his main one is that he's non-weight bearing on his left lower extremity. So when we are doing bed mobility and his transfers, we want to be watching out for that always, trying to stick to that 100%. In terms of his pharmacology, he's on antibiotics, which is most likely the reason for his complaints of fatigue and weakness. He is on both fast-acting and long-acting insulin because of his uncontrolled type 2 diabetes, and that's going to be the main cause for dizziness, but also we want to be on the lookout for signs of hypoglycemia when working with him. He is on a non-selective beta blocker, and this is concerning to me because the non-selective beta blockers will affect the beta receptors of the lungs as well as the ones in the heart, and this could have complications with his COPD. So I might want to talk to the physician about that and see if what the main reason for him being on a non-selective versus selective beta blocker is. Also, that has been known to cause his dizziness as well. Other medications, he's on statins, blood thinners, and a PPI, and those aren't too concerning to me. And then finally, he's on 2 bronchodilators, one that he takes twice daily, and the other one that he takes PRN. So with the albuterol, we want to make sure it's nearby during our treatment sessions in case he needs it. With his labs, both his white blood cells and his platelets are elevated, but they're trending down. So they're probably elevated due to the infection. It's a good sign that they're trending down, which means the infection would be going away. His hemoglobin and hematocrit are elevated, but they're stable. So this is most likely due to the COPD, and this could be the reason for his orthostatic hypotension and his dizziness, weakness, and fatigue. His electrolytes are normal. His glucose over the past 24 hours has been all over the place. It was 220, then 180, 190, and then 260. So this shows that's not controlled because if it was controlled, we want it to stay between the 140 and 180 range. This is most likely the reason for fatigue as well, and we're going to carry out with our eval, but we want to be watching these levels before we do further treatments and more intense exercise with them. And then finally, his A1C levels are still almost at 11%, which shows that this diabetes has not been controlled well over the last 3 months. In terms of imaging, so with his lungs imaging, he has hyperinflated lungs and a flattened diaphragm, which is consistent with COPD. His EKG was normal, which is good. And then with his echocardiogram, it showed a decreased ejection fraction, which is most likely due to his elevated blood counts and the changes of his cardiac muscle due to type 2 diabetes. With his personal factors, his wife was a previous nurse who is more than willing to help him when he does return home, so that's great for us. He no longer smokes, and he was previously independent, which is going to be very good for his prognosis. But the negative personal factors, he still drinks, he was not previously active, and he's currently obese. So these are things that we need to talk with him when we do consider sending him home. With the contextual factors, his living environment is kind of concerning. He has 3 steps to enter. Both his bedroom and his bathroom are both on the 2nd floor. He does have a half bath on the 1st floor, but if he does want to be bathing, we need to be able to get him upstairs. So we'll be including steps training in our therapy. In terms of examination components, the systems we want to prioritize are first a cardiopulm because of his presence of COPD and his history of cardiac stents being placed. We also want to check his neurovascular system because of diabetes causing decreased sensation and blood flow to his extremities. Also, we want to check his integumentary system because of the presence of infection on his surgical wounds. So we want to be looking for the incision area, always seeing if the dressings are CDI and then making sure the infection is progressing in the right direction. And then finally, we will be checking his mobility and his balance by doing some MSK evals. So in terms of his prognosis, his personal goal is to return to traveling as his wife and potentially going to Yellowstone. I think there's a poor prognosis to achieve that just because of his decrease in his ability in his mobility abilities. Also, we know that his ability to control blood glucose levels is directly linked to his prognosis. And so because they are uncontrolled currently, that's going to be causing a decreased prognosis. But in terms of returning home with home health, I think he has a fair prognosis. As long as we can get those blood glucose levels controlled and we can make a couple modifications to his home to allow a more safe environment and an easier environment for him to mobilize in, I think it's going to be a fair prognosis.